Why is this topic important? So there's many reasons, but here's just a few reasons of why this is an important topic for us to be exploring. We know that pediatric mood disorders are common and can have serious developmental consequences. So we know that especially the younger that a child is diagnosed, or the younger that a child is presenting with, for example, Jared being 8 years old, and the longer that that young person goes on without intervention and treatment, then that makes them much more vulnerable as they get older to more emerging mental health, social challenges, occupational challenges, etc. Another reason it's important for us to distinguish between problem behaviors and from behaviors that are typical of children. And so sometimes we can get caught up in, oh, that's pathological, we should diagnose this, when in reality, maybe that's more developmentally appropriate. But sometimes we realize some behaviors are not really developmentally natural or appropriate. We also know mood disorders can definitely run in families. There's the hereditary genetics aspect, which we could also argue part can be environmental as well, but there's definitely genetic um, link there that we find with mood disorders being passed from parent to child. I forgot the statistics, but I think it's like if a child has one parent with a mood disorder, their chances of developing a mood disorder is about 20 to 30%. But if they have two parents that both have mood disorders, it's about like 60%. So it pretty much doubles. So there's a lot of vulnerability there with that hereditary aspect in different generations. And then knowing risk factors and warning signs aids in that early identification and treatment, which is so very important. Summer, yes, sounds like it would be appropriate and important to monitor what is expected within age range and developmental stage. Absolutely. Yes. So let's start by looking at this kind of visual representation, and we could use this as an example for the client Jared that we were just talking about. Or we could use it for any young person that is presenting this moody child, this moody teenager. And again, we're really needing to differentiate between normal developmental life stages. We know that moodiness can present in really like any age of children, even young children, just like adults. That's one thing that I thought was always funny is um, adults maybe not giving as much allowance for children to have like a bad day or a moody day or to have like an irritable few days, but then adults like want a lot of understanding when they're having a bad day. And so I think we need to extend the same to children and understand that children and teenagers can go through moody periods and can have moody times in their life, and that may or may not be indicative of a mood disorder. But if we look at just this kind of moody child presentation here, we have two different possible outcomes. So let's start on the left. We start obviously with childhood, which is really the foundation of what we look at in terms of child development, both physical, emotional, social, cognitive child development, all of those different aspects of development. We know that there can be some stable premorbid factors influencing brain development. And so again, if we look at the power and of genetics and the research that has been done on genetics and their role in mental health, and I'll just give you a quick non-mood disorder example of the power of genetics. I have a training on hoarding disorder, and one of the statistics I have in that training is that 80% of people that are diagnosed with hoarding disorder have a first degree relative. So usually that's going to be a parent that also had hoarding disorder. 80%. So that shows you in a completely different diagnostic category the influence of genetics. And when we look at mood disorders, we certainly see that there can be that high probability there within some family lineages and genetical kind of patterns. Parenting, we know parenting, of course, is really influential in terms of children's development, perhaps some of how their temperament is managed or responded to, also in terms of rules, boundaries, limitations, respect for self, respect for others, discipline, impulse control, connection with parents, validating, nurturing parenting, all of these things that we know are very, very important. Temperament. Temperament is one of those things that is part of our core personality. Temperament can be influenced, of course, by genetics, environment, many other factors. Temperament, we find, is something that people usually have that is enduring throughout their life. Can people's temperament change? It can. But what we find is that people typically have around the same type of temperament as they age as they did when they were children. So, some children are just much more easygoing. If they get upset, they're able to kind of really calm themselves down. If there's a change in their schedule, the child is able to adjust. But other children really struggle with some of these things. And you may see that their temperament is maybe a little bit more on edge or a little bit more reactive, a little bit more difficult time tolerating distress or, having patience or having self discipline. And then finally, of course, attachment. We always look at attachment in the context of any childhood disorder. Very important that we have a frame of reference of one of these factors that can be very influential. One of the ways I know in social work we were trained to capture information on genetics and on family history was the genogram. If any of you remember the genogram, which had the circles, the triangles, the boxes, and we begin to identify at least two generations back what might be the presence of mental health conditions, of substance use, of other really noteworthy things in other family members in other generations. That is sometimes as close as we can get because we're not at a point where we have this advanced genetic studies that we have that we can do for each individual client and say, oh, yeah, you have this genetic family history of this that we found in your blood work. So we have to kind of rely on our own clinical skills and the information that can be provided to us. And sometimes there's not a lot there that we can get context on. Is genetics a factor in this case? Yeah, it's like the family tree, Monica, is that genogram, right? And it can yield a lot of very helpful information. We also know that there are vulnerabilities in brain regions involved in emotion and motivation. And so that is also really important. Again, going back to Jared, our opening 8-year-old, and looking at, the vulnerabilities that likely are existing in his brain regarding his emotions, but also his motivation, his focus, his attention, his self regulation. All of these areas could really be very impacted. And then you also see other factors: stress, income, physical environment, demographics, and education. All of these things lead up to this stress and challenge for this young person. And remember, this is a young brain. This is a young person's brain. They don't have that strong executive functioning yet. They don't have the adult knowledge and wisdom and skills and experience that we have. And so, if they're experiencing some of these vulnerabilities, how are they going to make sense of these, right? And the way that we often see children make sense of any of these factors is through their behavior, right? Which we kind of call symptoms. But really, we see that especially young people communicate to us through their behavior, whether that person is 4 years old or they're 14 years old. We're likely going to see some communication in terms of their behavior, i.e., symptoms. We know, for example, in adolescence, if you look at adolescence, so now we're looking at adolescence, we look at this whether or not the adolescent has intact emotional functioning. Part of this is going to, of course, depend on childhood. What have been their first, 12, 13, 14, 15 years of life like? Do they have intact emotional functioning? Or do they have more of this pervasive, dysregulated emotion and motivation? Then we see this transition to adulthood. This is our young adults. These are our 17, 18, 19, 20, 21 year olds. We look at either this resilience and intact ability to engage in adaptive functioning, or we see as they become adults, this heightened risk of continuing mood, psychiatric disorders, and other adverse outcomes, health outcomes, because now we see a very strong correlation between mental health and physical health. So you can have people that are in their early 20s that already their heart is already very much compromised. Their cardiac health, the cortisol that's been flowing through their bloodstream for many years is already creating damage to the cells within this young person's body. So that is why it's really important that we as providers that we can accurately assess, diagnose, understand these disorders and be able to provide the most help and intervention possible, not just to the young person, but to their natural environment as well. So let's look at biological risk factors for mood disorders in youth. And these come from a variety of different sources. So, including Mental Health America, we look at other organizations that work with youth. For example, the American Psychological Association has published some research on vulnerabilities, especially biological vulnerabilities for young people. So, this is by no means a comprehensive list, but begins to give us an idea of just aspects of our young clients that we need to be paying attention to, especially for those clients that have many of these different biological risk factors together. Being overweight, chronic illness, early puberty in girls, family history of depression, female sex, high functioning autism, LGBTQ identified, and polymorphisms in the serotonin, dopamine, and monoamine oxidase.